for eventually to go on the canvas. And so if you don't mind, no one's in the picture, but basically it's going to be up there for your edification later on. If you have any questions, consult the city Zoom recording. So it'll be up there. This is a big deal, this one today that we're going to talk about. Patient assessment is your way to treat everybody and to address every emergency situation that you have from here on out, from tonight until the end of your lives. Certainly until the end of your careers. I'm out on disability right now, and I was over at my father's house today, and he started shaking, and so I sat him down and found myself doing a patient assessment on him. So I haven't done a patient assessment in months, but as soon as the opportunity arises, I fall back on this thing. And that's what it's meant for you to do. This is supposed to give you a really good framework in order to carefully, thoroughly, and rapidly figure out what's wrong with our patients, but also it really works for every emergency situation. How to assess them and how to treat them, package them, and transport them to the hospital. And there's a lot in this. I'm telling you, there's a lot that goes into patient assessment. I don't want you to think it's very easy to do. There's a lot of moving parts. There's a lot of things that will expand and contract depending on how the severity of the call, the number of patients, what type of call it is. There are other assessments that can fit onto this patient assessment and build it out. For instance, like a stroke scale that I was checking today, there's a whole set of other assessments that you would put into this during the physical exam or during the rapid exam. And so you can fit other bits and pieces onto this skeleton and slowly construct your patient assessment so that you create like the He-Man of EMTs that you're going to become when you get out in the field, and nothing's going to get past you. You're going to assess everyone thoroughly. You're going to make the killer decisions. You're going to be saving lives left and right. And it's all based on this tonight. So there's a big responsibility, everyone. I want you to realize that. There's a lot that goes into it, as I said. And so don't think you're going to get it right off the bat. This is your midterm. This is your final. And you're going to be doing this from here on out. So every time you do it, you get a little bit better. You get a little bit more memorization, especially in the beginning. The learning curve is very steep. Is that what I'm singing? You get a lot as soon as you start getting over the hump of knowing where you're at, what you're doing. But then also you have to remember, you're trying to not only get through this correctly, but you're supposed to be retaining the information that the patient is giving you. And you're making educated decisions on how to treat that patient so that you keep them alive. So when we go through this, we're going to talk about the basic framework of patient assessment, what this is, what we use it for, how it works in terms of priority. In fact, it's ordered in a means that will, if you do it correctly, you won't overlook anything. And you'll address the really big issues early on in your assessment. And it's done that way to keep the patient alive and to treat this emergency situation effectively. You know the difference between assessments and the difference between treatments. You're going to know your role as a lead EMT, and that really has to do with assessing versus treating. And you'll be able to practice this assessment with your students. And I would say more than that, go home and practice this assessment on family, boyfriends, girlfriends, husbands, wives, especially children, especially old people. Because we rarely get the chance to assess those age groups, and the bulk of our calls typically are elderly geriatric calls, and when it's a pediatric call, the stress level is exponentially higher, and so you really want to know that you know what you're doing when you are assessing a child. And additionally, their anatomy is different, so their anatomy is literally physically and physiologically different than ours. And so The more you can practice and get good at this, the better it's going to be for you. And really for the patients, that's who we care about the most, right? Remember, it's not your emergency, it's the patient's. So whenever you get flustered and freaked out and you don't know where you're at, remember, step back. Not my emergency. I'm not the one dying. That person may be. I better put all my attention and compassion into that person. So it's an assessment, the patient assessment event overall. It's conducted on all emergency patient interactions. It can expand and contract to fit the need of any event. It allows for thorough and rapid assessing and treating and transporting. And it can be adapted really to address all emergency events. So fire department, hospitals, ambulance, civilian on the street, whatever the situation, whatever the emergency, be it a gas leak or a water main burst or a vehicle collision, or, you know, take your pick, loose dog on the road with multiple victims. Using the patient assessment is going to be utilized for that call. That's just simply how we do our job. It really makes sense, and it's a great framework to build off of. The broad view, basically, in essence, it's about 4 different parts. It's a scene size up, which you're doing really as soon as that call comes out until you begin treating a patient. A primary assessment, and we'll, for the ease of this lecture, we'll just talk about a single emergency with a patient. You don't have to make this very big right away. So this is, let's just say, you know, a fall for an elderly woman. So you do a scene size up. You do a primary assessment on that patient, followed by a secondary assessment and a reassessment. But as it opens up, it gets a little bit more involved. So what is inside your scene size up? Well, you have to do a bunch of things, and this is a really important step. This is pretty much everything you need to do to make sure that this call doesn't get any worse, that this call is handled properly and efficiently, and you don't lose track of what we're doing on this call. So here are some priorities when we're dealing with our job. Number 1 priority is, of course, me and my crew. Me and my crew. We need to be safe and healthy enough to treat all the people that are actually injured. So we look at risk. Really, especially as a firefighter, you look at it as this way. If I'm going to put myself in danger, is the reward worth it? Am I going to be able to take this person out of a fire? If I'm running in, are they already charred up, or is there a chance they're still alive? And if there is, I'm risking my life to save them. If that whole fire is fully involved and you can see flames through that whole room, there's nobody alive in that room. Why would I run into that room? Okay, so that's the thinking here. We will risk our lives and our safety, but for someone else's possible chance of survival. So keep that in mind. The last thing you want to do is commit into a scene, and now you're injured, and now another crew has to show up, and you're a patient along with the other patient. You're just making things worse. So decide on what is a calculated risk. And so that really comes down to BSI and scene safety. So we're saying, do we have all of our proper gear on? And is the scene safe enough for us to walk inside? This is the new accoutrement for every patient call now post-COVID. We're all wearing these things. So get comfortable. You're going to have calluses on the back of your ears. Before that, it was at least goggles and gloves, and really even goggles, you would use them when you were a probational firefighter or EMT, just so all the superiors could see you're wearing them. Okay, so he's doing it. He's following the rules, and then people get lazy and people would stop wearing glasses and everything else. Post-COVID, right now, we kind of re-upped everything. So always gloves, goggles because spit can get in your eyes, and at least a mask, a particulate mask. Now, when we're dealing with respiratory issues on the patient, so they have shortness of breath or they're coughing stuff up or they're whatever it happens to be, or I'm going in to do an intubation, I have to wear an entirely different respirator with cartridges and everything else. BSI is very important. Don't do something unnecessarily risky. So make sure you got gloves on, you got your partners wearing gloves. Another thing is though, like let's say you're getting out on a freeway. Part of BSI is going to be wearing reflective vests because they look super awesome. And it's something that you even have to wear over your turnouts and everything else. So that's part of BSI for that call. That's part of your BSI is body substance isolation. And PPE is another way of saying that's personal protective equipment. Same thing. So for different calls, we're going to need different pieces of safety. As I mentioned, on a medical car crash, you're going to put on the vest. You don't need to do that when you have a pregnant patient. But with a pregnant patient, you're going to be putting a gown on because a lot can explode out, especially when the baby's coming through and there's pressure on the bag of waters and everything else. So it really depends on what the medical call or the traumatic call is, which you're going to need. And then scene safety is really just, is this safe enough for me to walk in? And for most of the calls, it is. It's not an issue. But what if it's a hazmat call? What if there's some gas leaking from the side and it's this big yellow gas cloud? Well, don't walk in there if you don't know what it is. Scene's not safe. What about a car accident on the street? What do you think you'd like to have there before you get out of your ambulance and are standing in the street working on a patient? Traffic control. So what does that mean typically? There's some police officer there. Same thing with a shooting or an assault. You want police to show up first to clear the area because they have firearms. They're the ones that can handle that. We really can't. I've been in situations where people have firearms and we don't, and it doesn't feel great. It's unilateral advantage on their part, and I don't appreciate that. So in the future, if I'm not carrying one, I'm going to bring somebody there first who can carry it and take care of that. And then let us focus on our job, which is saving lives. So that's the first two big steps there. And I look at it as like this. I show up on scene and I go, okay, me, BSI, gloves, mask, goggles, vest, turnout, helmet, whatever. I'm good. Next person next to me, my partner, they're good. They've got the same stuff on, good. And then my crew's next to me, they're good to go. Okay, we're getting out. And we get out of the rig, and now my attention span goes from this to everything else out there. And I look at the whole scene safety, everything. Think of a car accident where you see glass shattered, vehicles overturned, people screaming. You need to take that in and just kind of say, okay, what am I dealing with now? What do I need to do to stop this from getting worse? And then we can work our way down. It's kind of interesting if you talk about actual terms of priority. I say I'm number one priority. Who's after that? My crew and me. Who's the next person who has priority? That's what everybody would say, right? Your patient. What's that? My partner. First, me and my partner, the rescuers first. Secondly, not the patient. It's everybody else. Yeah, responders included, but really the public at large. Because I don't want them getting in the scene and then getting injured, and now we're dealing with a whole logistical nightmare. So we go, me, my partner, my crew, we're good. Look out there. What do we need to get everybody else away from this? So get them out of the way so they don't get hurt, so that we can focus on the actual problem that's right here. And so with a car accident, that means getting traffic to go around this whole thing so they're not smashing into this and causing issues, which means police need to be there, which means maybe, we need other additional resources. So then I can focus on the number of patients that we have there. So now I'm looking at, again, car crashes, there's one at least, usually 2 or 3 or 4 or 5 or 6. And so number of patients really comes into play there with our scenario that we're talking about tonight. Just an elderly lady fell in the bathroom. I only have one patient, so it's not something I have to concern myself with on this call. Because of it just being one patient, we probably have enough resources to handle this one patient. But if it were 6 or 7 patients in a car accident, well, I know I'm going to need another fire ambulance, another fire engine, probably a couple trucks, a chief, several different ambulances from other companies to get there, because, well, we're going to need to transport and package and treat all of these people. And so we're going to need all of those additional resources. And that's why it's in the scene size up, so that we're thinking about this really just as we get out of the ambulance, or maybe even just on as the radio call comes in and they say multiple patient rollover or multiple vehicles involved in the collision. We already know chances are there's going to be more patients and we're going to need additional resources. So additional resources is more ambulance, more fire, more police, but it can be other things like PG&E, animal control. Those come into play very often. Yes. So usually that's all decided by the 911 dispatcher. So if someone calls and goes, oh, there were 6 cars, they all crashed, there's people everywhere. Well, they're going to know that's the case, and they start calling in like a rescue response. They'll call in at least 2 engines, a truck, a fire chief, and 2 ambulances. Okay, so they'll pretty much know that. But there are times when you get there and realize, oh, there's another car down an embankment. Nobody called that in. And so now you're calling in more resources. So remember what you've heard from the radio dispatch. And then as you're getting out, you should be thinking to yourself, is that going to be enough to handle this? Is there other stuff that I'm going to need? Good news is this: you're an EMT in an ambulance. You're the bottom rung. You're getting your feet wet for the first time. The people who really this is behooving to know what to do with is the fire company and really the officers, the fire captains and the fire chiefs, because they're getting there and they're in charge of the orchestration of this whole thing. So they will be doing that. But if maybe they miss it, they're not on scene yet, it's up to us to call for additional resources, tell dispatch what it is. And, that all comes in due time. Don't worry. You don't need to know how to do that yet. But that's a very good question. Yeah, sometimes it does fall on us to call for additional resources. Okay, so remember, it can be more than just fire and EMTs that you call for. You can call for other related services too. And then based on that, what is the nature of illness or the mechanism of injury? Usually we say NOI or MOI. Meaning, is it an illness call or is it an injury call? You'll see that there's a lot of rewording in this career. So basically, is it a medical or is it a trauma call? Or is it both? Because you can have both. You can have somebody pass out from a medical emergency and then crash into something. So you make an educated guess. And from that, you're going to get the idea of whether or not we need to take spinal precautions, whether or not we have to be concerned with how we open the airway, how we move the patient, and how we package that patient, determined by if there's any threat of injury to the back, to the spine, to the neck, to the body, to the neurologic system that will be damaged if we don't heed that caution. We don't pay attention to that and say, we got to move them as a unit. We're moving them slowly, and we're not letting them torque and move around, and we're certainly not pulling them out of the car because we don't have to, and that's not how we do things. So that's a scene size up. It's a lot. But really, all you have to say when you show up on these calls is, okay, so I got BSI, scene safety, number of patients, MOI versus NOI, need for additional resources, and C-spine. And it flows off your tongue, and you're going to be saying, oh, okay, I finally got I can remember it. But now remember, you have to eventually learn why we do those and when to implement those. So we went on that call. It was a code 3 response for an elderly woman who fell in the bathroom. We have my gloves and everything on. We have 1 crew. It's an NOI. There may be a need for a spinal immobilization. We have all the crew that we need. Do you know who shows up around here or in the Bay Area, at least pretty much across the nation for any medical calls, any 911 emergency? Yeah, so so like what's the full complement? There we go. Like, in other words, someone calls 911 for this patient. My grandmother fell in the bathroom. Who do they dispatch to that? Okay, so they dispatch, and how many fire apparati would they send? Yeah, one, and probably not going to be a truck unless the truckers are going to be angry if you send a truck because they want to be sleeping and cooking. But it'll be, if there's no engine available, certainly a truck. So it's one piece of fire apparatus, a truck or an engine, maybe even a squad, and then one ambulance because somebody's going to transport. So somebody needs to be there first and then start the treatment and assessing and packaging. And then the ambulance eventually has to get there, bring them to the hospital. The reason it works that way is there are, anytime in this city especially, or down in San Jose where I work, or Oakland, there are at any one time many more fire stations available to take a 911 call. Pretty much speaking of a skeleton for how operation is performed. Typically in this city, there's supposed to be 20 ambulances running at all times to field all of the calls. Usually it's between 5 to 10 on a good day. It's very common to go to level 0, meaning there's no ambulances available for any calls in San Francisco. Okay, and that happens a lot. Happens more than you would think. It's amazing. So because of that, the fire companies can be dispatched and they can arrive at that call sooner than an ambulance that's roaming around in the nearby, maybe 15 miles away or something in South City or something. So the fire engine gets there, they start the treatment, and then the ambulance company eventually shows up. So in this call, our additional resources would be me and my partner on an ambulance, and it would be a fire captain, at least a fire driver, an EMT, and a paramedic on the engine or truck as well. So they can do all the treatment that's needed until I get there and drive. So I'm usually on a fire engine in San Jose. So our job, we get there sooner. We begin the assessments, we treat, and we package, and then the crew usually gets there. And if it's a bad enough call, I will go with that paramedic in the back of their ambulance and continue treating, because there's probably, for somebody who's in cardiac arrest, we need to start IVs, we need to give medications, we need to continue CPR and ventilate, and maybe even shock a couple more times depending on whatever ends up happening. So it's better to have a couple people in the back of the ambulance. So if you think by the call's nature, you're not going to have that many people as additional resources, then call for them. But we get there, it's an elderly lady. Grandson lets us in, and now we got all our gear, we're done, we're squared away, we don't worry about scene size up right now, unless something makes us go, ooh, maybe we're going to need additional hands. Maybe that lady weighs 360 pounds. Probably not going to be able to lift that patient with the crew and everybody that we have. So we may have to call an additional resource. Anyway, we'll get there when we get there. We've done the best we could with scene size up that we could from where we were. And now we're moving in. And we're always keeping in mind we can alter our plans as we go. So our first indicator on how this patient is doing is when we first visualize or hear that patient as we come into the area. If we hear the woman groaning as we're walking through the hallway to get there, guess what? We know that she's responsive in some way. So we're trying to gain a general impression of this patient. And as I walk in, there's a woman laying between the vanity and the toilet. And there she is, and she's going, oh, she's hurt. Okay. What can I say about, and she's looking at me and she's like, oh, it really hurts. What can I determine from that? What do I know already about her level of consciousness? Okay, she's meaning what? Meaning what? She's at least she's alert. She's awake. Her eyes are open. and she's looking at me and she's groaning. She's alert. I don't know if she's oriented yet, but she's alert. So our first treatment is this: alert, verbal, painful, or unresponsive. Alert, verbal, painful, or unresponsive or unconscious. And what that means is when we show up on our patient, they may have their eyes open and they're looking at us as we go, which means she's alert. We still have to find out how alert she is, how with it she is. If she's not alert, their eyes are closed, and I say, ma'am, can you hear me? And her eyes open up, or she goes, yes, I can hear you. Then that means she's responsive to verbal pain, to verbal stimuli, to the sound. You'll see in San Francisco, guys, the crews will go, hey, buddy, get up. If they get up, that's verbal. They'll honk their engine horn. And if the guy gets up, well, all right, I guess that's verbal, or it's audible. If that doesn't work, we go over and do painful. It's not really painful, it's tactile. So I would go over and kind of grab on the shoulder. You okay? Hey, buddy, can you hear me? Or another one is a sternal rub. But you could kind of shake them, something like that. Something that is moving them around, a tactile stimulation. And that usually wakes up a lot of the ones that haven't responded to pain or from verbal. So think of that. Well, like, who would that apply to? Any of your drunk friends passed out on the couch that won't wake up when you're calling their name and you go over and start drawing on them and then they move around? Well, that's tactile stimulation. So that's that portion. And if none of those things work, then they're unresponsive. They're unconscious. Okay. So let's go back to alert. We would then ask these people these 4 questions to find out if they're alert and oriented to person, place, time, and event. Hi, ma'am, what's your name? I'm Sophia. Hi, Sophia, what's going on? She might tell you, oh, I fell down, I hit my leg, or I slipped off the toilet. Good. Can you tell me where you are? I'm in the bathroom. And do you know the date? It's the 30th of August. Good. So I know that she's alert to person, who she is, where she is, approximate time, where she, the date or the time of day or whatever it happens to be, and the event, how she got to be where she is that made somebody call us there. That's the event. So I would say that person is A&O times 1, 2, 3, 4. A&O times 4. So it's a little, see how it changes? So basically you're saying, are they alert or conscious to verbal or conscious to painful or unconscious, period? And they go, well, no, they're alert. Okay, so how alert are they? Are they alert to person, place, time, and event? Yes. Okay, so they're alert. They're A on the AVPU and they're A&O times 4. What's interesting is you've already learned this, if you haven't realized it, when you do CPR on somebody. When you see someone on the ground, what's the first thing you do? Good, see safety, good, exactly, scene safety. And then you say to them, what do you do? What are you supposed to do to that patient? Shake and shout. You shake and you shout. And if nothing happens, you call for additional resources. So you already know this step and it's built into the patient assessment. So you're already pretty much, through with this first part. So good, you got a head start. Okay. So that is how we're forming we're really trying to gain a general impression of this patient through this portion of it. We've done their mental status is what we've just ascertained from the moment we saw them to the moment we've asked those 4 questions. We've determined their level of consciousness, their mental status. There's another one we'll learn later on when we're doing trauma calls, which is a little bit more in depth. But for now, it's A&O 4 and AVPU. Next, we're going to move into, so here's somebody sleeping. Look at this guy. Actually, I'm going to get back to him later. Now we've done our general impression and we move on to airway. And this is where you say AVPU, A&O times 4, and ABCs. What are your ABCs? In fact, don't forget ABCs. Always be closing. No, ABCs. This will get you out of more trouble than you can imagine. Whenever you get lost in your assessment, step back, check ABCs. Whenever they're shouting and things going psychotically wrong, look down at the patient and check their ABCs. It's written as ABCs because it's supposed to be as simple as ABC. You could technically say P for pulse and BP for blood pressure, but essentially what's it saying? It's what's their airway, what's their breathing, and what's their circulation. And how do we assess their airway, their breathing, and circulation? And how can we treat their airway, breathing, and circulation to keep them alive? So when we look at the airway, is it patent, which is our fancy term for open? Is their mouth open? Is their airway blocked or not blocked? And you can block it with foreign substances, foreign bodies like choking hazards, or it can be blocked because their head's sloped to the side and they're passed out and their tongue's in the way, or their mouth is being closed because their neck is tilted off. And all of these are just kind of signs of incomplete blockage. Snoring or sonorous respirations is what, there's another technical term we call it, sonorous respiration. It's snoring. It's snoring. You've heard it. That's partial airway obstruction. We can fix it by putting their head straight, head tilt, chin lift. Same thing with gurgling, like that kind of thing, you know, gurgle sounds, incomplete airway obstruction. And stridor. Stridor is a little bit deeper. It's in the larynx. Usually, a really serious stridor would be from burn inhalation or anaphylaxis, like a massive allergic reaction. The airway starts to swell up with fluid, and it starts to get smaller and smaller and smaller, and you're whistling air as you breathe. That's a form of stridor. That's a form of incomplete airway obstruction. So we step back, we look at this grandmother. When we've been talking, this patient we have, is the airway open for this woman? Yeah, it's open. She's talking. She said to me, I fell down, I'm hurt. All right, well, airway's open. Now, what's her breathing? What's her quality of respirations? That's a whole other lecture I will get into. But what's the quality? Do we note that there seems to be difficulty breathing, or does she seem to be breathing all right? And so we will then decide, okay, adequate rise and fall of the chest. Do we see that? Do we see labored breathing? Do we see shortness of breath? I can't breathe. Or even worse is like, you know, they're going, can't breathe. All right, when did it start? Like they won't answer any questions. The worse off you get, the less words you can say to answer the people. So, you know, oh no, it just feels like I really can't catch my breath. I mean, it's like I'm really short of breath. Okay, we might feel that way, but it's not to a life-threatening level yet. So, so determined by the number of words that they use in their sentences, complaints of, you know, something hurts or a short of breath or whatever happens to be, and lung sounds. We can, at this point, technically do our first auscultation, blood stethoscope, and listen to lung sounds. This might be an appropriate time to do it, or it might come after this ABCs and general impression when we get to a rapid assessment. Okay, so there are things that I didn't show you on airway. If it's not open, well, we got all these cool things that we've already shown, right? Head tilt, chin lift fixes it. Tongue jaw thrust, moving the jaw out for trauma patients. And then these other things you weren't learned, what, 2 weeks ago? OPAs, NPAs, and suction. Those are great ways. They're airway adjuncts. They open up the airway. So maybe those are the time to use these. Maybe now is the time to put in an NPA or an OPA on your patient if you hear if they're snoring. Well, maybe an NPA will go past that spot in the soft palate and open it up and they can breathe a little more easily. Who knows? Likewise, when we get to breathing, this is your opportunity to give oxygen. And depending on their quality of respirations, we'll decide on a particular oxygen delivery device. Most patients could benefit from oxygen and probably could have a nasal cannula. Nasal cannula gives you just, you know, a low flow of oxygen, but in cases where people are hurt, sometimes it is a minor pain reliever and it may help that call. If, though, you are noticing some difficulty breathing any shortness of breath, any signs of accessory muscle use, of tripoding, of 1 to 2 word sentences, of, you know, rapid shallow breaths, we're going to need to bump that up to at least a non-rebreather. At least a non-rebreather is for any respiratory distress patient. And anybody remember the level of oxygen that a non-rebreather gives you, or what you set it at? 10 to 15, beautiful. So that gives you at least that. You can always bump it up too if they're sucking the reservoir closed. And then if, and this is more for if the patient is unconscious or is getting there, get out the bag valve mask. Get that bag valve mask out, because you will be using it very shortly. So what we try and explain, hypoxia or inadequate ventilations, is that we're going to use this for people whose breathing is very rapid or very shallow. You don't realize people can still be conscious with a very rapid respiration. And sometimes, unless you're very trained in using these, shoving a bag valve mask on somebody's face who says he's drowning, he can't breathe, and just going, here, just hold this here and I'm going to blow air in when you breathe, sir. Like, you're going to make the situation worse. We don't have to do that anymore. Luckily, we have CPAP, and well, within a few 30 seconds to a minute, those patients are going to crump. They're going to go unconscious. And then we can lay them down, and then we can do positive pressure ventilation. Hopefully it doesn't come to that, but that's what we're trying to do. Remember, patients that get the bag valve mask are usually unconscious or dead. That's when we use the bag valve mask. And I know that really doesn't get shared that often, but that's when that comes in very handy. And other than that, usually you can take care of any of the respiratory issues with the non-rebreather, okay? And then finally, circulation, peripheral pulses. That's really what we're checking. Do we have this? If they're unconscious, we skip the radials and we go right to the carotid. Because the thinking is, if their heart is stopping or they are going into shock, they're going to shunt blood to the heart, lungs, and the brain, and they're going to pull it away from the body's going to pull it away from the periphery, from the arms and legs. So check the one place that they should absolutely have a pulse. And you check a carotid, see yes or no. And if no, we do CPR. And if yes, well, then we continue on with our assessment. Why don't we do a carotid on people as soon as we walk into a call? There's not a cut and dry answer, but it is a little bit intrusive when you walk into somebody and go, hi, how you doing? And I stick my finger in your jaw or into your chin. It's a lot more polite to start on the arm, on the wrist, and work your way into that call, because eventually we will be doing a head to toe assessment. And you're going to be palpating and touching and listening and squeezing and everything else. So we check circulation, we check pulse, skin signs, capillary refill, it's okay, and blood pressure. And I say blood pressure here. Now, if you are alone, you're going to wait and do the blood pressure. But on our call for this elderly woman, it's me and my partner, and it's a fire company. And if I have the worker power to do it, I will do it. What I ideally want at the end of my general impression, or at the end of this initial scene size, or this initial patient size up, is I've assessed their level of consciousness. I've assessed their airway, their breathing. I've given some kind of oxygen delivery technique or device to them. And I've checked all my vitals. I've gotten a baseline set of vitals. I've gotten pulse and blood pressure at the very least. Skin signs we'll get because you're touching and palpating, and you'll feel warm, pink. You'll see if it's pink, or if it's dry, or if it's diaphoretic. And so by the end of that, I've now kind of gotten a full general impression of my patient. I've noted their level of consciousness. I have a set of vitals which tell me stable or unstable or going unstable. And then we basically want to find out what their chief complaint is, or what their chief concern is, or what we're there to deal with. And that will be how we move on to the next portion. So we'll take a 10-minute break. Come on back, stretch out, and we'll start in about 10 minutes. You. So cool. All right. So where were we? Back at ABC and general impression. And do you see that okay? Yeah, why don't you click the light real quick here? So what we're forming here during this primary assessment is a general impression of our patient. We've gotten that through a level of consciousness, which we've checked through ABPU and ANO4. We've assessed their airway breathing and circulation by checking respirations, their head positioning, accessory muscle use, etc., giving them oxygen and the amount that they need, and assessing circulation by checking a pulse yourself, and then having your partners check the blood pressure as well. By the way, you will be the assessor on these calls. The person who is going through and conducting this patient assessment is the lead EMT. That's what we will call you for the remainder of the class. You're the lead EMT. You are the one who's being graded. You're the one who's assessing and going in and saying, okay, BSI, seat safety, need for additional resources, NOI, MOI, and number of patients and need for additional, and C-spine. Okay, now I'm showing up my general impression of my patient is that they're alert, they're conscious, they're looking at me, they're oriented, and you're going through that. You doing that is the lead EMT's position. So if you were the one on the scene with the highest amount of training, you would be conducting the patient assessment. You would be the lead EMT. Usually it's the paramedic. If there's a paramedic on scene, they're the one with the most medical training for the assessing. So they're doing it. So based on all of these things, you are going to tell your partners, I'd like them on a nasal cannula at 4 liters, or geez, can you get a nasal cannula? Your other partners that you will be working with will also be at least EMTs, especially in the field. So they'll probably dial in the right amount of oxygen for you. Or you'll say, put them on a non-rebreather. They'll put a non-rebreather on. I'll ask them, would you mind getting a blood pressure and pulse and respirations? And I'll have a partner do that. But I will still check a pulse and I will look at their quality of respirations. And that's how I'm determining who is going to do the treatments. So the treating is all of the care we're going to render for that patient. The assessing is all the information that you are inputting into your mind and attempting to diagnose and attempting to treat properly with the tools that we have, i.e. oxygen, medication, C-spine. So that is being done through your primary assessment, through your general impression by getting LOC, level of consciousness, ABCs, chief complaint, whatever that happens to be. And but from those issues, we're looking to see if it is a big sick call, a load and go, or a little sick, or a stay and play, or however you want to say it. Are they going to die right now, or do we have time? They're not going to die, right? An elderly lady who fell in the toilet and she's stuck there. She's in pain. Is she going to die right there? The injury that she has is not life-threatening. So chances are, unless we start finding other things out, she is going to be a what? She's a little sick. She's a code 2 transport. She is a stay and play, meaning we're not rushing to get this patient off scene. We can stay on scene, not necessarily play as the credo says, but take our time and go through a lot of the evidence, and we'll be okay taking our time. So that is by the end of your primary assessment, your general impression, you should have that information. And from there, we're going to delve deeper into the patient's injuries or illnesses. We're going to start treating those injuries and illnesses, and we're going to get a history of that patient, past medical history, as well as a history on how that event that we're there to treat came about. What were the steps that came about for that? In some cases, it's very obvious. A fall is a fall. That's why we were there. But why did they fall? So you got to figure that out. Like, when did the pain start? Well, when I fell and hit my hip. Okay, obviously. But in terms of chest pain, that's very different. Chest pain started, well, what were you doing? Were you working out or were you sitting, sleeping? Because that indicates different issues. That can indicate exercise, exacerbated maybe what's the word? Acute angina, or this could be an embolus, a clot in their heart that lodged itself without exercising. It just suddenly happened. So it changes the medical call by assessing their immediate disability or their immediate complaint. So what we're going to do for our major calls, which we've already done for any unconscious patient that doesn't wake up and appears to be either dead or on their way there, is we do a rapid physical exam. You can also do a rapid physical exam briefly on what body part is injured or they're complaining of. So a rapid exam is quickly, what are they complaining of? And if we can't tell, if they can't tell us, then we have to quickly analyze the body and figure out if we can see something that's wrong with them. Usually it takes 60 to 90 seconds, and you're searching for life threats. That's issues with airway, breathing, or circulation, i.e. they have something lodged in their throat, or their airway's not open, or they're not breathing, or they're bleeding out everywhere, in which case we're going to put a tourniquet on before we really do any further assessing on this patient. It doesn't do us any good to do a thorough assessment on a person who has died because we are taking our time and thoroughly going through each body parts. Meanwhile, they're bleeding out of an amputated limb. So we got to handle the ABC stuff first. Okay, we got to handle the life threats first. So this physical assessment could be quickly looking at them and going, nothing I see so far. I like to have two different things that we do. Your rapid physical exam is the same way you would do a detailed physical exam, except you can go through it and take your time on a detailed. And then we're going to do questions. We're going to ask questions. We're doing a physical and we're doing a sample OPQ RST. So we're going to get to here. Okay. So we're going to do a physical exam or a history on their injury and their medical past. Okay, so this is a little bit on there. So what were we doing for this physical exam? This is really the nuts and bolts of this call, of this event, and what we do with it. And I will go through each body part with you when we get up after this lecture. Essentially, it is a head-to-toe examination of this person where you're looking for any irregularities starting at the head and going down to the toes, followed by the arms and the back. Why do we go in that order? Again, this is built according to priority. Why would you start assessing for life threats at the head and then the neck and then the chest and then the abdomen? Well, where are all the things that are going to kill you? Injuries and illnesses to the head, to the neck, to the chest, to all the organs, everything there. If there's a gash inside there, well, there's a lot of bad things that can happen to you, a lot of irreversible things. So we start at the highest priority and work our way down into lesser and lesser life-threatening places. So it is important that we start at the head, go down to the legs and out to the arms, and then check the back. Doesn't mean that if you get on a call and somebody's laying face down, that you can't very rapidly check their back and then roll them over, right? You could still do that, especially if they have like a piece of rebar sticking out. Probably you don't want to roll them over onto that too, so keep that in mind. You can do kind of those quick little, well, let's just check this first because I don't want to have to then re-roll them over to check their back. So ideally, all of our patients, when we treat, we have them in this position. Face up and anatomical position. In this position, all of the nerves and the blood vessels are aligned. They work naturally. Typically, pain resolves if you can get them in this position. And so we tried to do that with all of our patients. We're going to lay them in anatomical supine, back on the ground, face up position. That's the way we'll put them on a backboard. This is the way we're going to roll them after we've checked the back. And that way, usually things work better on our patients. And we can visualize face, eyes, nose, mouth, neck, body parts. We can see all those things and assess them and then reassess them and see if they're getting better or worse from our treating. So head to toe, really, we are going to take several minutes conducting in this class because you are going to verbalize every step in that procedure. I'm starting at the head and I'm looking in the eyes to see if they're pearl, if I see any bruising to the nose or face. Is there any blood or cerebral spinal fluid coming from the nose or from the back of the ears or from the ears themselves? Do we see blood or cerebral spinal fluid or bruising? We're going to go down to the face, the jaw, open the mouth, look for foreign body airway obstructions, look for loose dentures, blood, other secretions, suction if need be, go down to the neck. Is a trachea midline? Do you have JVD? Do we have a stoma or a medical alert tag? And on and on and on down the body. And that's what we're assessing for. You're not expected to know that tonight, so don't sweat it. When we do this in class, usually due to the verbalization and people slipping up and trying to remember where they're at and skipping and coming back, it usually takes about 2 to 3 minutes for you to do a physical assessment of head to toe. When you're doing this in real life, usually it's not even 60 seconds because you are looking, you know what you're looking for, you're visualizing, you're stripping, you're taking clothes off, you're flipping, you're looking at the whole body. And if there is bleeding or if there is cerebral spinal fluid, you don't have to stop and say, okay, I'm looking for blood, cerebral spinal fluid. You're not telling anybody, you're going to see it. The trick is you need to learn it in this class to know what the hell it is if you see it and go, uh-oh, okay, I do see this. What am I supposed to do for that? Note it, keep going. So you are going to take longer than it will take in reality. A real physical exam, usually it's between 30 to 90 seconds, depending on are you stopping to stabilize wounds, bleeds, something of that nature. Are you immobilizing? By the way, as the lead EMT, again, you won't be doing any of the treating. You're assessing, you're assigning your crew to do the treatments. You're assigning your crew to put on the bandage over the eviscerated intestine or put the splint on the midshaft femur fracture. Of course, you're responsible for them doing it correctly. So that's why you want to have a really good crew where you work, because as the lead EMT, you're the highest trained professional. And so anything that goes wrong, it's going to come back on you. So in reality, maybe even 30 seconds duration, but 60 to 90 seconds duration is the length of that rapid physical exam. And you can reassess later in the ambulance on the way to the hospital. You might want to go back and do it a second time to see if those injuries have changed. But this is initially one of the two things that you're going to need to conduct after your primary. A second is a history of their medical past and a history of their present chief complaint. The present chief complaint, or what's a better way of saying that is chief concern. Instead of it being a chief complaint that they're complaining of, it should be the chief concern that you are concerned with that may kill that patient. So that's what we're doing. We have this really ridiculous acronym, sample OPQRST. I don't think I put it in here what that actually stands for, did I? What's that? Yeah, and OPQRST. Okay, and what else? OPQRST. Now it is that little brief number of those letters in a row, right? OPQRST. Yes. So it is that middle of the alphabet. Great job, everybody. But nevertheless, it's a little difficult to follow. So I will write that up on the board. This is a way, this is a means to find out what has happened to them in the past, which is very important for medical calls, and a way to differentiate their pain or disability or their unusual sensations from all the different complex medical or traumatic conditions that could cause it. So would you mind turning on the light? I'm going to write them up here to explain them to you because this is the first time. Okay. And again, this is going to come up all the time in the rest of your careers as lifesavers. So signs and symptoms, that's what this means. S here is, whoops, signs and symptoms. This is actually OPQRST. So the S in sample is actually, we'll get to it in just a minute, OPQRST. So when I show up and say, what are we here for? What's going on? And they go, my chest hurts. That's their sign. That's their symptom, rather. A symptom is something that somebody complains of. A sign is something that you can see or smell or touch or something like that. That's a sign. So let's say this woman is saying, my hip really hurts. Okay. Well, now we need to know more about that hip pain because it could be a femur, it could be a hip issue, it could be something hit it and bruised it. We need to start differentiating that pain and figuring out, well, what was the onset? What were you doing when that pain began? The onset of that pain. And she says, well, I started feeling, no, I won't even do that. All right. Yeah, I started feeling sick and I got up and I lost my footing and fell and hit the corner of the vanity with my hip. Okay. The onset was when she hit her leg on the vanity. Okay. Doesn't tell us a lot. Now, if this were something like, oh, I felt faint and then I lost my balance and fell to the ground. Well, now this gets into an issue with chief complaint, which I'll get into later. But the onset, what were you doing when this occurred? P is provocation, or if you want to get fancy, also palliation. So provocation is what makes it worse. When you provoke this, what makes this situation worse, and what makes it better. There's no E on palliation. What makes it better and worse? Is there anything that makes this pain better or worse? Yeah, if I move, it makes it worse. If I sit in this exact position, I'm okay. Okay, so that's provocation is movement, palliation is being still. Q is quality. And what that means is what's it feel like? And we want an open-ended question to answer that. What does it feel like? To explain the pain or describe the pain to me. And it just feels sore. It's like throbbing. It's not, oh, it's like terrible pain. That's going to be down here. This is explain the type of pain. For instance, this is going to come in handy for chest pain calls. What is a typical chest pain that's a heart attack feel like for these people? Some descriptive explanations of chest pain for cardiac patients. What's that? Tightness. Yeah. What else? Heavy. Have you ever heard heavy? Dull, heavy. There's an elephant stepping on my chest. It's just really tight. Those are descriptions of the quality. That's very different than they say, I take a deep breath and there's this shooting pain right here. Okay, well, that's a totally different kind of pain. I'm going to start thinking maybe not cardiac, maybe pulmonary, maybe musculoskeletal, something else. It's not cardiac because it's not typical cardiac pain. That doesn't mean it can't still be cardiac. There's all sorts of anecdotal ways people feel pain, but if they started describing the quality of pain as sharp or tearing I would stop thinking heart attack. I would still try and cover my cardiac bases, but I would be looking into other life-threatening issues like pulmonary embolism, like an aortic aneurysm, something like that, that might be the real underlying cause. And you're getting that by asking this OPQRST. It's the explanation of their chief complaint. R is radiation. Where does it go? Where does the pain go? Where is it? So it can be, that's really the big one, is where does it go? Sometimes you'll see it as region and radiation. Where is your pain and where does it go? For instance, for a chest pain call, where do they say they also have radiating pain? Maybe some people, there you go. Left arm is the big classic one. They have left arm pain. Sometimes up in the neck and the jaw, even in the back. So that's an example of radiation. This is that other one. It hurts a lot. You're asking them, on a scale of 1 to 10, how severe is this pain? And so I only mention this because these are the ones people mix up all the time. Don't fall into that trap. They're two different things. Quality and severity are very different. And then T is time. T is time. How long has this been going on? And it can also be, I'll write this up for you. How long? And it could be like a constant or intermittent. Like, is the pain coming and go? It's getting real bad and then it goes away. Or is it like slowly getting worse? Or is it immediate? 10 out of 10 pain hasn't changed whatsoever. That is the S portion. Expand it out. Like I keep telling you, this stuff is written in little acronyms and it's like, oh, I need a scene size of primary, secondary, and reassessment. Well, yeah, but there's more involved in all of those. And so when we get to our secondary, sample OPQST is sample. The S is all of this. This is according to the patient's chief complaint. So that's why we're there that day. We are asking this in terms of their chief complaint. When did the chief complaint begin? What were you doing? What makes it better or worse? What's it feel like? Does it pain go anywhere else? Or the discomfort include other things? How bad is it on a scale of 1 to 10? And how long has it been going on? Now, here's a question. Does it have to be pain? Could you theoretically do this for, let's say, shortness of breath or dizziness? Okay. Or altered level of consciousness? If you had somebody there that was able to answer those questions, maybe if they're too altered for you to get it, you could theoretically use that for all of the chief complaints. And that's what C/C stands for. My only issue with chief complaint is that, let's take that case of an altered patient who we know were there for altered level of consciousness. And you say, well, what's going on? What's bothering you? You go, that guy keeps coming in the house and he's bringing in, he's wearing that jumpsuit, or, and you go, wait, no, they're hallucinating. They keep seeing this guy come in a jumpsuit. And their complaint, she goes, he just keeps coming. I'm just so sick of him. And so I called 911. So that's her technical complaint. But that's not why we're there. The chief concern as EMTs, the life-threatening emergency, the CC I like better is concern, not complaint. Likewise, there are a lot of times, not a lot, but there are, I've had a few where somebody has been in a high-speed vehicle collision and they've done internal organ damage. And I'm noticing that it's starting to bruise, they're unstable in their chest, but they've also wrapped their fib around the accelerator and they've exploded their leg where there's open fractures with blood and bone. And all they can talk about is that leg. They're in excruciating pain. And I don't blame them. But they're just, my leg, I don't know what to do, and they're screaming bloody murder. But when all is said and done, is that going to kill them or is the internal organ going to kill them? Yeah. So my chief concern is their eviscerated organ or their lacerated liver. But their chief complaint and their concern, their chief complaint is their leg, which is horrible, but it's not going to kill them. So when we talk about this, that's just a little side note to keep in mind. This is the chief concern. It's what we're saying is, what are we there to fix this day? What are we doing there in the event? And that's what we're asking the OPQRST about. Okay, and so this is all about the day that we're there, the minute we're there. Tell us about that issue now. Now we want to go back in time and ask about all this other stuff in their past, because a lot of times on medical calls, whatever this is going to give us insight into what we're dealing with now, like dizziness or chest pain or something. So A stands for allergies. Okay. M is meds, medications. I'll draw it out. P is past history, medical, trauma, or otherwise. The abbreviation for history is H(x). Last intake is L. And again, the events leading up to this. So with this patient that we're talking about tonight, this old lady who's fallen and hit her hip, are we going to learn a lot from this? Well, let's see. So we go through. Are you allergic to anything? Yeah, I'm allergic to penicillin. Does that change anything for this call? It might. If this is a patient who's starting to have hives and sweating and they go, I'm allergic to bee stings and I just got stung by a bee. Allergy is very important there. Not so much on this call, though. Medications. Well, then she says, I take Plavix, I take C.A.R.E, and I take warfarin and Coumadin because I had a recent surgery. Is that going to be an issue tonight? Very possibly, because those are blood thinners and there's something else going on in her system recently. And so now maybe the medication can be something we need to concern ourselves with. Okay, all right, good. All right, so now past history, well, I found out she has a recent surgery. She has a history of high cholesterol, high blood pressure, and some cardiac issue that she's also on blood thinners for. Last intake. Some people will say last oral intake. I think it's better to ask last intake of anything, because on the weekends, 60% of your calls, the last intake was some kind of alcoholic substance that is causing the recklessness that you're there for that night. Car accidents, jumping off of building roofs to jump in pools, whatever you got. Last intake can be not just food or drink. It can be drugs, alcohol. You can intake coke by snorting it. You can intake heroin by shooting it. I want to know all those other things that are in the system, because it might play a role in how we handle that. And then E, the events leading up to this. So what again happened? How did this all come about? That is your sample OPQRST history. And so what I really like about this is that the S, the signs and symptoms, the first question you ask is, O, onset. What were you doing when all of this started? And the last question you ask after you go through that, boom, then you come back and you do all this. The E is, so let me get this straight. You were going into the bathroom, you lost your footing, and you hit your hip. Yeah, okay. You also have a recent surgery, you're on some blood thinners, and you can, at this E, review all of the things you've just assessed, and then tell that story back to the patient and see if there's anything you've gotten wrong. So it's a really good opportunity for you to then put it in your own words and go, okay, so let me get this straight. And you go through it, and then you can say, and you fell and you hurt yourself, you're on Plavix, C.A.R.E, and you had a recent surgery and you didn't have anything to drink. And did I miss anything? She goes, yeah, I'm on warfarin and Coumadin too. And like, oh, thank you. Okay. And then your last oral intake, you didn't eat anything. And so that's why we're here now, correct? Yes. Or correct, no, there's another thing that you missed or that I didn't tell you. And it's very important to have that happen at some point between the area that you're picking them up and the entrance to the hospital, because where you don't want it to happen is when you're telling the nurse in the hospital while you're handing off patient care, they start giving a whole different story that somehow you missed to the nurse. And the nurse is like, what patient did you treat? Because that's not this one. Because you missed their history, their vitals, you know, you didn't get it right. So what's nice is that when we get to the end of our secondary on sample OPQRST, we get to ask events, and we can then encapsulate, I guess, I don't know, what's the word? We're taking all that information and kind of processing it and giving it back to the patient to see if that is everything we needed to get. That's everything that was needed for that secondary. Summarizing and what? Confirming. That's beautiful. Summarizing and confirming. Let's write that up. So that is that first part. And what I think is best is that IR, yeah. All right. And we're running through that with our patient. That is the questions we ask. Now, that goes along with a physical exam. Which one do we do first? We have to do both. Every patient gets a sample history assessment and a head-to-toe assessment. So do we have to do them in that order? Do we start with history and then do the physical exam? If you want, you can, but I don't do it that way. I tend to break it down like this. Medical calls get the sample OPQRST first, followed by a head-to-toe. Trauma call gets a head-to-toe first, followed by a sample history. Now, let's say the patient's unconscious. Well, I'm not going to be able to do a sample, so I'll just go right into a head-to-toe, right? So the call kind of determines which one comes first, depending. But here's my reasoning behind this. If it is a medical call, very often we're going to gain insight from a sample OPQRST assessment. And the sooner we get insight onto the current medical emergency they're handling, the better. So I'm going to ask a sample OPQRST on my medical, on my nature of illness calls. Remember back to the scene size up. On the nature of illness calls, I'm going to do a sample first and then do a head-to-toe after that. On a trauma call, most of the time that patient was doing just fine until they got hit by a car or fell off a roof or whatever it was. In which case, I want to see exactly what happened to the body when it was involved in the trauma. And so I'm going to do a head-to-toe first on that call. And then I can get to a sample history at some point, maybe in the ambulance on the way to the hospital or wherever it happens. So you set priority according to nature of illness or mechanism of injury, according to it, whether it's a medical emergency or traumatic emergency. That's my default on that situation. There might be situations where you start talking to this old lady that we have, and she says, oh, I started getting dizzy when I stood up and then fell and hit the ground. And then next thing I know, I'm stuck back here. Well, that actually starts to sound like a medical issue, not a trauma issue, right? There's an underlying something that caused that patient to pass out. So in which case, you know, you can go with, you do the best you can. You're going to do both, so it doesn't matter. In reality, it only takes about 3 minutes to get all of that stuff. So really 3 minutes in the scheme of things, 3 minutes in the scheme of things is more or less negligible as long as you're treating as you go. As long as when you're assessing things and you find an issue, treat it and handle it. And that you've done your general impression correctly so that you know, you're not wasting time doing all these things. So what's nice is that this sample can wait. If it's a load and go, we're doing, right? If this is an unconscious patient that we talked about, cardiac arrest, unconscious, won't wake up, I can't do a sample. And so I'm going to do a head to toe, put them on the ambulance and go. And maybe they wake up in the ambulance and I can do that sample then. Maybe I can handle that on the way to the hospital. So we're not wasting time on scene doing both of these procedures. Okay. Whew. Okay. Oh, it is up there. Sorry, guys. Forgot I put it in there. Okay, so there's your OPQRST. Okay, then after you're done with the OPQRST, basically we then do a reassessment on this patient. We've done our treatment. We find out what's wrong with them. We've been treating our patient as we go down the line. If they have chest pain, if this patient's in pain, well, I'm not, I might have to put a splint on that leg as I'm doing my head to toe. My crew is then treating that injury. And then we get done with that, and we're going to do a reassessment. Usually the reassessment occurs somewhere in the ambulance on the way to the hospital. As long as you have gotten these vitals at some point already on scene, then the next time you do them, you're reassessing. So we've gotten blood pressure, pulse, respirations way back here. Way back here, okay? And now we're just reassessing. By the way, here's some good pulse points to check out. So, yeah. We usually don't check the lateral temporal pulse, but some people it's very pronounced. You can see this thing, especially when they panic. You see this big thing throb in their heads. Carotid, we know that one. The brachial, we don't usually check for a pulse, but what are we using the brachial pulse to get? Blood pressure, great. Typically, we're relying on a radial, which is by the thumb, which is as dumb as it sounds. I always imagine rad, man, radical. That's the thumb side. That's just any way I can remember this stuff, the better. So radial on that arm. It's also the bone that spins. So that's got a radius to it. Usually an ulnar is still there, but we don't usually go for that. It's much softer, much weaker than the radial. Femorals, we're usually not stripping people down to their bare naked body unless this is a cardiac arrest and you're performing CPR. One of the two good spots to check a pulse to determine if it's adequate compressions is the carotid and the femoral. If you're doing good, deep pulses, strong compressions, they will have a femoral pulse. So that's a good spot to check on. We get down to the back of the leg, the popliteal pulse is back there. And then on the can y'all see this? I'm popping off my feet for you, my shoes up. So here's the Dorsalis Pedis. This is the dorsal portion of my foot. Pedis means foot, so it's the dorsal portion of the foot, right there. And then there's one actually back here behind or posterior to the tibia, thank you. Behind the tibia, posterior tibial, there's another pulse. And that one you can even care to come over here, break and see it. Yeah, mine, you can see it very easily. When do we check pedal pulses? We're supposed to check them on all, but when do you think it would be important to find out if there's circulation down the leg? Yeah, exactly. Any leg breaks, any femur fractures, any fib fractures like the one I mentioned in the cars, we want to make sure that there is distal circulation. So that's very important. And when we splint things, we check pulse, we check circulation, we check sensation. Do they feel which toe we're touching? And movement. Can they wiggle their toes or press them? So we'll get into that later. So that's your basic pulse points. I go through my ABCs. I do a quick head to toe and a sample. Based on what I find there, I treat, and then we package and transport them and get the hell off scene. And we get moved into the hospital. This is saying sometimes in that case of severe patients, you may not be able to get that secondary. You may not be able to get that sample OPQRST. So if you have an available crew and opportunity, absolutely do this. You will need to do it at some point. Secondary assessment will take place on scene or en route to the hospital. And in some cases, if they're critically ill or injured, time is short, there is no assistance, you're not going to be able to get that secondary. So ideally, you have enough support that you can get that stuff, or you have enough resources that you can. Otherwise, how is the patient going to get their information to the hospital? Well, maybe the patient is a member of C.A.R E, and you bring them into C.A.R E, and they have their, they have the information on them, and they can say, oh yeah, they had previous heart attacks or whatever. They're allergic to latex or something, But otherwise, you're just hoping for the best. So here are some interesting places to find medical information from the patient. Let's say they are unconscious, or they don't speak English, or you don't speak their language, or they don't want to talk to you, whatever the reason. You can ask the patient. If that doesn't work, have the crew ask family members. So, and I wouldn't, and I say the crew because I wouldn't leave my patient and just start talking to other family members. But what's really nice is a fire captain who's usually writing the information down will go to the family members and say, do you have a list of medications or, a list of her medical problems? And that can be really handy in getting information that doesn't get across from the patient to me, the lead EMT. Where else? Well, if there's nobody else there, well, then you can ask the caregiver. If it's not a loved one or family member, you can ask, maybe there's a home attendant, or they're in a nursing home. The nurses should have that information. But also, even if they're all alone, check bathrooms and kitchens. Why is that? Or in bedrooms on the end tables. Why is that? Well, yeah. Yep, exactly. So you find all of their meds sitting over there. So these are just typical places that you might find medication. There's something called a vial of life. That is this, it looks like a giant medication bottle. And in it, they put them on the refrigerators, and they put in a whole sheet of the patient's medical history, date of birth, meds history, allergies, etc. And you can just, boom, we got it. And then write all that stuff down, and now you're good to go with that secondary. All right. And then we reassess. And then, if you can, in the ambulance, we might want to do a secondary reassessment, all that stuff. So your EMT crew will do this for you in terms of assessing. They will get you a second set of vitals. They can also do things like pulse oximetry or oxygen saturation by putting the pulse ox on the finger. They can also, you can all now do blood glucometry. You can check a patient's blood glucose, which is very key specifically for altered mental status. That's a leading reason, is some kind of hypoglycemia or hyper, but usually it's hypoglycemic patients. I think it's about, is it 8%, 8 to 10% of the population has diabetes, which is rising due to type 2. But I would say somewhere between 70 to 85% of our calls will involve a diabetic patient. Because diabetes does extensive damage to the body. Sugar is a literal acid, and it eats away at your body's interior. It eats away at the blood vessels. It eats away at the little intricate portions of the kidneys. It eats away in the capillary beds of your eyes and your nose. So blindness is very common, and bloody noses and everything else. So do your best to avoid diabetes. Anyway, let's take another 10 minutes. We'll come back at 7. And as we're rounding out, we'll probably now put this into practice. So I want you all to be able to get up and move around and see how this operates. By the way, this is, I gave you all a patient assessment for a medical patient. So you can kind of browse this and look on with me as we do one in class when we get back. Any questions? Good? All right. I'll see you at 7.